Good morning. It's a pleasure to be with you this morning to talk about breakthroughs in vascular neurosurgery. I'm Mandy Binning. I have no disclosures other than I have a ton of material to get through, so I'm going to start right away. I want to first start talking about what is vascular neurosurgery. What are some of the pathologies and conditions that we treat? I think there are the obvious conditions such as ischemic stroke, carotid disease, intracranial atherosclerosis, hemorrhagic stroke from aneurysm or AVM. But how about some of the less thought of conditions that a vascular neurosurgeon may treat, such as trauma, subdural hematoma, arterial dissections, pseudotumor cerebri, soon to be hydrocephalus, tumors with tumor embolization and chemotherapy. We also do diagnostic testing before epilepsy surgery, before pituitary surgery, and treat epistaxis. We have two general categories of treatment, craniotomy and laminectomy for open microneurosurgery, and then our less invasive endovascular approaches for coil and glue embolization, stent placement, and intra-arterial therapeutics. By far the most common conditions we treat have to do with the stroke. In the stroke realm, it's the leading cause of disability in adults and the fifth leading cause of death in the US. Most stroke is ischemic, but about 12% is hemorrhagic. We treat about 1 million strokes annually of the ischemic sort, but we treat about 30,000 aneurysmal subarachnoid hemorrhages annually. That said, I think intracranial aneurysms are a perfect model to describe the evolution of vascular neurosurgery over the past 30 years. So prior to 1995, when the first detachable coil for intracranial aneurysms was invented, all aneurysms required a craniotomy. We didn't really have a specialized neurosurgery team or neurosurgery call schedule. It was unheard of if you had an unruptured aneurysm that you would go in one morning and go home the next day after treatment. You fast forward to 2021, and 80+% of all intracranial aneurysms are treated endovascularly through the groin or the wrist. Vascular neurosurgery is a subspecialty of neurosurgery with a dedicated call schedule of surgeons, dedicated teams of nurses, techs, and physician assistants, nurse practitioners. And if you have an unruptured aneurysm, it's commonplace that you would come in the morning for your treatment, stay overnight for observation, and go home the next day. This is our team of comprehensively trained open and endovascular neurosurgeons, Dr. Errol Vesnadaroglu, Kenneth Liebman, Dr. Zakaria Hakma, Dr. Rudy Rami, who just joined us in July, and myself. We have on-call 24/7 specialized nurses and techs who come in at a drop of a hat to do our vascular cases. This is our cerebrovascular neurointerventional team, and our patients are cared for by ourselves, but also dedicated physician assistants and nurse practitioners on the inpatient and outpatient side. So here's an example of a case that I think shows a great dichotomy between even 10 years ago how this aneurysm would have been treated. This is a 27-year-old presents to us with a sudden severe headache. A sentinel headache means her CAT scan is negative, but she has the worst headache of her life. And she has this internal carotid artery aneurysm that she's actually known about for about 5 years. But when she discovered the aneurysm, or when it was discovered, she chose not to follow up. But she's always carried the CD of her aneurysm in her purse. So we pull up the CD and we can prove that the aneurysm has grown about 5 millimeters, and she has this sudden severe headache. It needs to be treated. So rewind about 10, 12, 15 years ago, the only treatment for this aneurysm would be to take down or totally occlude her carotid artery, leaving a 27-year-old with one carotid artery, or a very morbid surgery of craniotomy and bypassing the external to the internal carotid artery. But this year we can treat with flow diversion. We now have 3 different types of flow diverting stents, so we can choose which one we need for the specific aneurysm. What the stent does, it diverts flow away from the aneurysm and remodels the parent vessel, so that immediately as the stent is placed, we already see stasis within the aneurysm. You see the aneurysm is just full of the contrast. It's not going in or out, it's static. So over time, the aneurysm will thrombose, and at 6 months, the aneurysm is gone, it's cured, and the parent vessel is totally normal. This is a 72-year-old male who presents with a subarachnoid hemorrhage, a patient of Dr. Hakma's, and he has this large basilar tip aneurysm. 30 years ago, this would have only been treated with a craniotomy for clipping, which would have left him with a high risk of stroke or cranial neuropathy. And even 2 years ago, this would have been treated with stents and coils, which requires putting a subarachnoid hemorrhage patient on dual antiplatelet therapy. But this year, we can treat with an endosaccular device called WEB, or a woven endobridge. This is just a cartoon of how the WEB works. It actually goes intra-aneurysmal or intrasaccular and fills the aneurysm full of platinum and nitinol so that it can't actually re-rupture. So this is the post-op image. You see everything we want to stay open is open and the aneurysm is occluded. This is a patient of Dr. Lehman's, a 70-year-old female who presents with this massive hemorrhage from a ruptured middle cerebral artery aneurysm. You see the aneurysm here. Can you make that play? You see the aneurysm on this slide, and soon it will play. It's a middle cerebral artery aneurysm that Dr. Lehman was able to treat with endovascular coils, and that's both because of his great skill, but also because of our technology. Our coil technology allows us to make complex shapes with the coils so that this patient with a large hemorrhage can actually go on to have her aneurysm treated within 10 minutes, have her bone plate removed and the clot evacuated, and at her 6-month follow-up, her aneurysm is cured. And she's doing a lot better. She's starting to walk, she's starting to speak, but she has this unruptured aneurysm on the right side. We'd like to avoid bilateral craniotomies in this patient who's already had an insult to the dominant hemisphere. So again, we can use this intrasaccular device. She doesn't have to be on dual antiplatelet therapy, and she's cured after placement of a single device. This is a patient of mine who's 74, and he had a prior craniotomy 30 years ago for a subarachnoid hemorrhage. You can see the shadow of the clip there. And he's a little cognitively impaired because of the subarachnoid hemorrhage, and he comes in with a TIA, so we actually want him on antiplatelets, but we discover this left middle cerebral artery aneurysm. I don't want to do a craniotomy because of his prior craniotomy and cognitive impairment. But now our technology is such that we have stents that can expand to the size we need, but they're small enough to be delivered through a catheter, the same catheter that we use to coil the aneurysm, doing this all through the wrist. So as soon as he wakes up from his intervention, he can sit up, eat. He doesn't have to be flat, doesn't have to be on bed rest. And this is his angiogram after treatment. Everything we want open is open, and the aneurysm is not. That said, there are still aneurysms that require clipping. Those that are larger than 10 millimeters are too large for a WEB device. Multiple lobes, if they're clotted or thrombosed, if the branches come off of the walls. We always do what's right for the patient, which is the benefit of being able to do both the open or the endovascular. Our technology doesn't guide us. We guide the technology for what is best for the patient. So this is a 42-year-old who presented with a sudden spontaneous headache and this subdural hematoma, and had a correlating aneurysm that was large. It's about 15 millimeters, very dysplastic looking, not amenable to endovascular treatment. But we take her to our hybrid angiography suite where right after we do the angiogram, we turn the table, turn a craniotomy, clip her aneurysm. This is actually a clip developed by Dr. Vez. He likes to call it a chip clip. And it works just like you would expect a chip clip to work. Come right down on the aneurysm dome and clip it and exclude it from circulation. Then we turn the table, prove that the aneurysm has been cured, and then she wakes up knowing that she doesn't have to worry about it again. I'm going to switch gears a little bit to arteriovenous malformations and really talk about the breakthroughs in technology for embolization. This is a 36-year-old with a ruptured spinal AVM. And the branch that's feeding this is about 1.7 millimeters, so tiny. I mean, think about 1.7 millimeters. We have balloons now, miniature balloons, that can actually go into this pedicle or this branch. And not only do they inflate to prevent the glue from refluxing and to keep it going forward, but it actually has a working catheter, or we can inject glue through the balloon so that the glue is going forward. You see the balloon inflate here and the glue going forward, and this allows us to cure this particular AVM with gluing of one pedicle because of this technology of the tiny balloon. Now, not all AVMs can be cured with embolization. Some still require surgery. This is a 44-year-old presents with left leg weakness and this ruptured AVM. And there's a little intranidal aneurysm. It's best cured with surgery because it's very compact and we can cure it with surgery. We have technology through our microscope. So while we're looking through the microscope, our anesthesiologist can inject a fluorescent dye, ICG, into cyanin green. This AVM is in our field. But after resection, you see our field is clean. All you see is a little bit of flow in the draining vein that has been clipped. And this gives us an idea that there's no residual AVM, so that then we can turn the table, do our definitive intraoperative angiogram, and prove that the AVM has been cured. This is technology that is giving us better outcomes and more confidence in the patient's confidence that once they are done with surgery, they are cured. I'm going to switch gears a little bit to ischemic stroke. It's not front page news that thrombectomy plus TPA is superior to TPA alone, but probably many of you have read in your newsletters or your journals that there's been a lot of talk about skipping TPA. Prior to thrombectomy, these trials were called Mr. Clean No IV, the Shrine collaboration. And what they found basically is that it's not inferior to skip TPA and go straight to thrombectomy, but superiority was not found. And it did not decrease the risk of hemorrhagic transformation. So I think as I could speak for the group to say, really there's no downside to giving TPA if you have time and it does not delay thrombectomy. That said, here's a case of a 66-year-old who presents to our ER within 2 hours onset of right side hemiplegia and aphasia. She's on Coumadin at home for AFib. She's got this left MCA occlusion. Her CTA and perfusion that shows a large penumbra was actually done before blood was drawn for her INR. Our team is sitting there ready. The room is set up. I said, you know what, we can probably have that clot out before we have the INR back. And so we take her to the angiography suite where sure enough, she's got a left MCA occlusion. And she undergoes thrombectomy with a device called a stent retriever. It's been around for a while, but essentially what it does is opens up a stent to grab the clot and pull it out. The image on the left is the stent retriever in place. And I can tell you when we get the image on the left, the lab calls and says the INR is 1.7. She would have been a candidate for TPA, but we had already pulled the stent retriever, and the image on the right that already played, we were able to get full revascularization or TICI3 flow. So before we could even get an INR back and mix TPA, we had already opened the vessel. So I think that's an example where you can use the literature to really take an individualized approach to do what's best for the patient. She was actually discharged home neurologically intact on post-op day 2. I had talked about how we treat traumatic disorders, and I'm going to couple that with the DAWN trial, which we were a part of, and this extends the window for thrombectomy up to 24 hours, which is important because about a quarter of strokes that we treat are noticed upon awakening or 24 hours out. The DAWN trial enrolled 206 patients, and really what you need to know is it was stopped early because thrombectomy compared to medical management showed a relative reduction in disability of 73%. So this is a patient of mine. He's 43 years old, and he had a traumatic injury because he was choked out in jiu-jitsu class. And we came to, he was intact, but he went home, went to bed, and woke up with hemiplegia and a gaze preference. He did not get TPA because he was beyond the 4 hours, and he was actually beyond 9 hours from last known well. And so he did get perfusion imaging, which shows a large penumbra of the right MCA distribution. He's got a little completed infarct in the basal ganglia, but it's almost all penumbra. And as you can imagine, because of the traumatic injury, he has a dissection, a very extensive dissection of his right internal carotid artery with a large thrombus that had actually embolized and occluded his intracranial carotid artery and MCA. So now we have large catheters, large bore catheters. We can actually aspirate all of this clot out, and you can see some of the clot that we were able to remove, able to get the MCA open right away just with one pass, and then we had to stent the carotid artery. Now he's not on aspirin Plavix because we didn't have the benefit of loading him before he arrived acutely. But we do have a great medication now. I like to call it IV Plavix. It's called Cangrelor, and it's a P2Y12 inhibitor with a 2-minute onset. So we can place these stents acutely now and not worry about the stents thrombosing while aspirin and Plavix are absorbing. We can then get them loaded with aspirin and Plavix, and there's a 1-hour offset of this medication. So it's really been a game changer. So carotid artery stenosis, you probably typically think of carotid stenting or endarterectomy, but we've been offering a new treatment that is exciting called transcarotid artery revascularization, and it's really for selected patients. It's not for everybody, but in selected patients, it's very safe and actually effective. So this is a 54-year-old male with stuttering TIAs and new onset AFib. If you look at his right carotid artery, he's got this kind of goomba sitting there that we think is a thrombus from his AFib. So we actually anticoagulate him for 6 weeks, bring him back, do another CTA, and it's still there. It hasn't changed. So if you look at his angiogram, he's got a long segment of string sign, a very tight stenosis that goes to the C2 level. So he's not adequate or not ideal for endarterectomy. And I don't want to just place a stent like we normally would because I'm worried about that embolizing intracranially. So we do a procedure called TCAR, transcarotid artery revascularization. And what this is a direct cut down on the carotid artery, and we access the plaque or the thrombus through a large sheath in the carotid artery. What this allows us to do is bypass the aorta and any sort of plaque that would be in the aorta. And it also allows us to reverse flow, because what we want to prevent is any plaque or thrombus embolizing to the brain. So flow is reversed, it's filtered out and returned to the body through the femoral vein. Once the blood has been filtered out and reversed, we can actually place the stent very safely, and you'll see that here. Once the stent's placed and we're sure that all of the debris has been filtered, we can actually pull the sheath, close our incision, and this is our post-stenting picture. There's no residual stenosis, and he had a great outcome with no residual TIAs. Now, again, like I said, TCAR is not always appropriate. For example, this patient with a very heavily calcified plaque, this is still most appropriate for carotid endarterectomy, and it's a great treatment. We still follow the CREST trial guidelines, and again, the importance of being able to do both. We're not just, we don't have one tool, we have all of the tools so we can choose and tailor the treatment for the patient. So here a very large calcified plaque was removed. This would not have been a good stenting case because the balloon and the stent could not have cracked that calcium to open up the vessel appropriately. I want to switch gears now to a condition that's not classically thought of as a vascular condition, idiopathic intracranial hypertension or Pseudotumor cerebri. This is a condition of papilledema, increased intracranial pressure, often seen in obese patients, and classically it's been treated with Diamox, weight loss, ventricular or lumboperitoneal shunting, or optic nerve fenestration. A subset of these patients have venous sinus stenosis. So here's an example of a patient, a 27-year-old female who presented with bilateral blindness and headaches. She'd actually been blind for a couple of days and came to the ER, and I mean blind, not even light perception. Her MRI demonstrated findings consistent with Pseudotumor cerebri, and her opening pressure was 63. Now, the RIVER trial actually looked at this subset of patients, and if you could stent that transverse sinus, it showed a 90% reduction in papilledema and pulsatile tinnitus, and an 80% reduction in headaches. So this patient very much has a transverse sinus stenosis. You can see where the yellow circle is. This is her dominant sinus, and actually at angiography you can see the stenosis as well. And we place a catheter across that stenosis and measure a gradient. And on the distal side of the stenosis, the pressure was 63. On the proximal side, it was actually 15. So she has a gradient of almost 50. And after stenting, we measure the gradient, and there is no gradient. Everything is normal. Now, what I can tell you is after the stent was placed, we check on her in the neuro ICU about 4 hours later, and she's looking at the TV, and she's already starting to see lights and figures. It's very blurry, but at 6 months, her vision is almost normal, and her papilledema has resolved. Now, what about trauma? I mentioned subdural hematomas earlier. This is a 64-year-old who has a platelet disorder and thrombocytopenia, and he's got this acute subdural hematoma on the left side. He's actually having seizures, so it's symptomatic. But because of his platelet disorder, we can't correct him even with platelet transfusion, so he's not a candidate for craniotomy or burr. So we offered him middle meningeal artery embolization. And we're actually going to be part of a randomized trial called the CHEST trial in the near future, looking at surgery versus MMA embolization. This is a patient of Dr. Hakma's who underwent the embolization. This is his angiogram, and the inset here shows the middle meningeal artery. This is embolized with glue or particles. And then after embolization, you see that the MMA is gone. The artery you see on the screen is a superficial temporal artery. And the thought process, or the theory behind this, is that the middle meningeal artery is actually giving blood supply to the membranes that can leak and feed the subdural hematoma, causing it to grow. And so if the blood supply is gone, then the subdural hematoma can absorb over time and not continue to enlarge. And sure enough, this is a follow-up CT only 1 week later, where there's no acute blood and the subdural is about half of its original size. And it goes on to completely resolve within 3 months. This is something very exciting that I want to spend a little bit more time on. This is a patient of Dr. Vez's, a 64-year-old male with a GBM. And this is a case of intra-arterial chemotherapy for GBM. He has a little bit of enhancement near the ventricle, periventricular enhancement, and you see all of the flare signal change or edema around that enhancement. And what Dr. Vez is doing is finding the artery or the pedicle that's feeding the tumor. So you can see the tumor blush on this injection. And rather than delivering chemotherapy systemically through the body, through the IV, where it can cause a lot of side effects, this is very targeted delivery to the tumor itself. Now, we know it doesn't cure the tumor, but what we can do is really decrease the peritumoral edema, the side effects or the symptoms from that edema, and actually treat the tumor at the same time. So this is his post-op MRI day 1, and you already see decreased enhancement, decreased mass effect, and the proof is in the pudding. On post-op day 1, his speech was much more clear, his right-sided weakness had cleared up significantly, and he comes back every 2 to 3 weeks for this treatment to basically give him increased quality of life rather than decreased quality of life, which you often get with systemic chemotherapies, and give him a therapeutic option for his tumor as well. Finally, I want to talk about what I'm most excited about, and that's hydrocephalus. You wouldn't think a vascular neurosurgeon would be excited about hydrocephalus, but I would say it's the most common condition treated by neurosurgeons, pediatric, adult, across the board. The first VP shunt was placed in 1958, and I have to say I don't think the technology has changed since 1958, except for maybe valve technology. We can adjust a valve with a magnet now. Wow. But the valves and the shunts still get clogged with debris. They get infected, and really they are a nightmare. So what if we could actually place a shunt intravascularly? This is actually going up through the venous anatomy, the inferior petrosal vein. This is a trocar that punctures the vein and delivers a shunt that sits in the subarachnoid space and drains via a gradient from the subarachnoid space into the vein where the CSF is absorbed. Now, all of the catheter and all of the devices are removed except for this tiny catheter that sits in the vein and absorbs CSF. Now, this has been done first in man. It's not ready for prime time. There are unknowns. We don't know durability, how long it stays open, if it has to be replaced. We do know if it does have to be revised or replaced, that's easy to do. But this is coming. So in conclusion, breakthroughs in vascular neurosurgery are allowing us to treat a multitude of neurosurgical disorders not ever really thought to be in the neurosurgical realm. Our treatments are becoming less invasive, more effective, more durable, and our hospital stays are becoming shorter with less downtime. So with that, I would take any questions.
Thank you, Dr. Binning. That was great. That was awesome. We had a question. There are a bunch of questions about the evaluations, which I think we're answering. The other question was, there's obviously still a concern about IV TPA and bleed rates. What is the bleed associated with a thrombectomy?
So all of the randomized trials actually showed that the risk of hemorrhagic transformation or conversion with thrombectomy was not higher than the risk with TPA alone. And so that's really part of the benefit of doing TPA plus thrombectomy, is that you had improved outcomes, improved independence without a higher risk of hemorrhage. So we don't really think the bleed rate is much different whether you just give TPA or just do thrombectomy or do both.
That's great. Any other questions in the audience? Well, it generated a lot of questions, which we can talk about off camera. Thank you very much.